This is Carol from COXO Sales Department. Today, our webinar topic is irrigation, the game trend in the endodontic treatment. Our professional is Dr. Shalu from India. She is second time to cooperation with us. Last time we got a lot of good feedback. Before the webinar, I want to introduce how to get the certificate and how to win the lucky gift. Okay. Now let me show you. Our lucky gift. Today, our lucky gift is Titan high-speed handpiece. Titan is a 4-hole sprays, and the bearing is improved bearing, so it have a longer life, and it has special angle to more convenient for operate. And we also compare with other brand the cutting force. The cutting force is increased a lot, and we also have compared with other. Because the special structure of the cartridge, so this one have the lower nose. So this is for this webinar gift. I hope please leave your comment on the live show, and we will pick up one lucky person to get this Titan gift. Okay, now I will introduce how to get the certificate. The first step, you need to follow our page and like as your page. And step 2, leave your comment or question below the live video. Leave your question after finish this lecture. Our professional Dr. Shalu will answer your question. And at the end of the live show, we will share the phone link to the comment below the live video. So please open the link and fill up the information and apply the certificate. About 3 steps is all done. In 5 days later, you will receive the PDF phone certificate in your email. And there have 2 notes. Note 1 is the application form will be filled up for only one time, so it's only available for 5 hours after the lecture. So please, if you want to get the certificate, you need to fill up the form as soon as possible. And second, the message cannot be modified, so please be sure the information you left are correct. And here is our certificate sample. We also have the speaker, the professional signature, and also the stamp from COXO. Okay, this is how to get the certificate and our gift for this lecture. During this webinar is a special festival in India. So our local dealer supports the special discount during this webinar. Okay, now I want to introduce our local dealer Saramango Company CEO, Mr. Andy. Hello, Andy.
Hello, Carol.
Okay,
Yeah.
Now I give you some minutes to introduce this your company and COXO in Indian, and also you can speed some discount because you say they have the special you have the festival in India in next
Yes.
week, so you have a big offer, a big promotion for the dentist, so you can
Sure.
introduce it.
Yep.
Okay, this time I will give for you now.
Yeah. Hello, everybody. Happy Diwali to everybody. Now, I just want to introduce our company, Sarvamangal, to everybody. Now, Sarvamangal is a company which has been in dentistry for last 21 years, and we are in collaboration with COXO for Indian operations. So, I'll just show you. Uh, just a minute, I'm just sharing it. So, I hope you are all are actually seeing my screen.
No, Andy, no, I cannot see your screen now.
Now, can you see?
I can see only you, but your PowerPoint I cannot see.
Uh,
You need to add your PowerPoint and share it.
yeah, I'm sharing my screen
Yeah, yes.
actually.
Now I can see.
Yeah, you can see it, right?
Yes, right.
Okay. So, Sarvamangal and COXO welcomes all eminent dentists who are attending our series of webinars. And happy Diwali to everybody. So, Sarvamangal is basically a consist of it's a group consisting of many companies called Sarvamangal Healthcare Private Limited, Sarvamangal Enterprises, Acumen Services, Sarvamangal Healthcare Innovation Center, which is our research and development firm, and we also run a charitable trust called Dr. B. N. Kulkarni Charitable Trust. Now, Sarvamangal is a vision, and the vision is always good to all. As our name suggests, Sarvamangal. We are proactive, innovative, entrepreneurial, with all integrity and dignity. To brief our organizational structure, we have a board of directors for Sarvamangal Group, then we have departments to have a working. So we are very professional in working. Our main logo and vision is to build a stronger dental community prepared for all future challenges. We want to provide dental practitioners with the equipment that keeps them ahead of the competition. Want to optimizing the treatment workflow, creating a platform for modern techniques and patient communication. Sarvamangal will constantly work to meet and exceed the expectations of our customers. And Sarvamangal means effective solutions for dental practices and clinics. Our goal is to find new ways of offering something better than the best and providing customers with the ultimate smile that lasts longer. As you all design smiles for your patients, we try to design smile for you. We we and along with the COXO, we want to become a respectable dental alliance. We had been together for quite a long time. So, COXO, as it is having a sales network in 158 countries, and for which Sarvamangal represent them in India. So, for any sales and service queries or anything, any programs you want, you can contact us. Sarvamangal is the COXO is there from 2003 and Sarvamangal from 2000. So, our association is growing strong from 2007. We are providing all sales of COXO's world-class equipment with the backup of best service, ensuring dentists to have peace of mind in usage of COXO equipment. Now, various equipments which are already in the market, control memory files, SC Pro. We are These are one of the best files you can find, and with a very special particular sequence. Then we have endomotors with COXO. All these endomotors, they are having Swiss made motors inside, so they give you accurate uh, control over your motor. The torque which is shown and torque which you get or the speed what is shown on the screen and what you get on the file are the same. They don't produce any ledges. They will give you a constant torque, it will not jump the torque. So Sarvamangal is very proud to offer wide choices on endomotors, which all are available in India. We have one of the best curing lights. This curing light also has got inbuilt caries detector, which we give along with the goggles for caries detectors. These are having a cordless machine with two batteries, double charger, and also a power indicator along with. We have apex locators. This is you will find YouTube videos where it is compared with Jmorita and gives the same result. It is C root I plus. We have downpack and backfill, one of the best in the market, with the very good quality of tips, very economical, at the same time very effective. Our downpack comes with five tips of different sizes, so you can do your lower one third in a very good position. Backfill comes with four tips, four needles, 23 and 25 gauge. Also, we have electric motors. We were one of the first to introduce these in India also. uh, these had been in the market for quite a long time. It is used for by many European companies and also is in India for last 2 years. We are shortly will be introducing the new models C Puma Master and C Puma Mini in coming month. We have caries detector, paint and alginate mixers also. The one of the best implant motors or physio dispenser what we call are there, C Seller Pro and C Seller Plus. You can always, our logo is just a call and that's all. So Sarvamangal Healthcare Private Limited is situated in Sangli. You can find us with our email addresses. You can follow up our page SHPL India, and all queries we try to respond within 12 hours and give a solution within 24 hours. We have company trained engineers for precise service. So now you can always avail the special Diwali discounts we are giving, which will be up to 15th of November on all COXO products. You can always contact us, Sarvamangal 9823048686. That's our number. Thank you very much. Over to you, Carol.
Many friends, many thanks for Indian. Many thanks
Thank
for
you.
Sour Mango support in Indian market.
Yeah,
Thanks for
thank you,
you,
Carol.
Andy. Thanks for your time. Okay, if
Yeah,
have any Indian dentist, please leave your comments. Say hello, hello from Indian, and I will
yeah,
know you. Many thanks for
yes.
Andy. Okay, I will introduce our uh, Dr. Dr. Shanu from Indian to give our lecture today. Tonight, our topic is irrigation. Irrigation is very important during the treatment. Now, I give the time for Dr. Shanu. Hello, Dr. Shanu.
Hi, Carol. How are you?
I'm fine. Nice to see you again. Okay, now I will give the time for you. If any dentist have question, please leave your comment on the live show. Thank you. Take your time.
Um, a very good evening to one and all. Myself, Dr. Shalu Mahajan, and I'm a private practitioner practicing in Muradabad, which is a place in India. So today we are going to talk about this is my Carol. This is not my second; it is my third webinar with COXO actually. So I'm fortunate to be here and to share certain clinical tips that we I can share with my colleagues. So today the topic that we have selected is a very clinically relevant topic, that is irrigation. And I call it the game changer in endodontic treatment because it is. So, to start my presentation directly, I would start with this case of mine. This case comes to me with acute pain. The patient is a young female, a young male patient, and he comes with a lot of pain. And this root canal treatment was done maybe a year back, and he had extreme tenderness on percussion as well as on palpation. So when we look at this radiograph, we don't find actual any major problem with this treatment. Maximum what we can think about any missed canal, because as far as the radiograph is visible, the white lines shows that they are not so short, the obturation is not so poor, the coronal seal seems to be good. Then why this case is failing in 1 year? So I had to take one CBCT, and under magnification, under microscope, when I examined or when I looked for any extra canal in the mesial root, I could not find it because it was not there. So such cases, when they come to our practice, they are like eye opener to us. Then why does this such case they fail? Even after the previous dentist found out the entire root canal system, I mean the root canals, and no root canal is missing, and there is nothing special anatomy, then why do such case fail? So when such cases come, we have to rely and believe that something is missing. And what is that missing link? I feel the missing link is irrigation, because the retreatment was done non-surgically, the working length was taken, the shaping was done, the previous obturating material was removed, and what extra thing or extra time I gave was for irrigation, the irrigating solution under rubber dam application, and the procedure was done in 2 sitting. So when you see such cases and you get positive results on follow up, they make your belief even more stronger that the main game changer in endodontics is not shaping, it is not instrument, it is not any fancy thing. It is basically the irrigation. And why do we need irrigant is a big question, because our tooth look very simple. It's been ages that we are dealing with the teeth. Everybody is we used to think for past before 7 to 8 years, it used to be a very simple process, root canal treatment. What is special, what extra? Everybody was happy and satisfied seeing the good black and white beauty on the radiograph. But what happened in last few years, why this curtain raiser was came into picture? Because of such anatomical configuration or the root canal system that we don't see it on any radiograph. We don't even see such intricacies on any CBCT images, but they do persist. So when you see such micro CT images and the beautiful images by Dr. Vasiani's book, they make us believe that such intricacies are impossible to treat mechanically. No instrument can reach to these area. What can actually flow down is our irrigating solution, and that is a trick. If we can make our irrigating solution flow down into these intricacies, that is the idea of a good root canal treatment, or our right approach towards an endodontic treatment. As we all know, these landmark study by pack, the clarity that they gave, that even after the best of the best rotary instruments, they cannot touch the entire root canal walls. So the area which is left behind untouched is more than 35%. So, and this happens more in oval shaped canal, which is obvious because our rotary files are round in shape, and oval shaped canals are really difficult and tricky to touch. And that is the reason why we see most of the failures, especially in C-shaped canal morphology or wide canals, where initially we were just preparing and filling it with a single cone without giving more emphasis on cleaning as well as three-dimensional seal. So the more and more failures came in past few years, which actually made us to think again why we are failing again and again. So cases like this, in which a case which was totally non-responsive for past 10 years, and when the tooth was extracted, the histology showed a presence of biofilm between the isthmus area into the root canal system. So these things are eye openers, because on radiograph you or I won't be able to see anything of such kind. Everything will look up, perfectly normal. What is lacking is lies inside the root canal system, which can be seen only through histology, which in clinical practice we never see. So, why I'm showing these pictures is to make you understand what is the need of irrigation in our root canal treatment. We cannot reach into these areas with any kind of mechanical instrumentation. So, the thing which can reach and clean these intricacies is only our irrigating solution, and we have to understand that. So there are various components of root canal complex. First of all, root canal is a system. It is a complex. It is not a simple a round or oval shaped canal. It is a system, and it has got multiple lateral canals. It has got accessory canals, apical delta, anastomosis, isthmus, apical ramifications, and so many intercommunicating intricacies. So when we look and understand these intricacies, it becomes very obvious that these areas cannot be reached with any kind of mechanical instrumentation. So, why is it so talked about topic irrigation? If it is a system, if irrigation can flow into these areas after a complete, a good shaping, then why do we talk so much about it? Why are we always worried? Why do our cases still fail? Why don't we get 100% outcome in our non-surgical root canal treatment? Because we have lots and lots of challenges. The disinfection is not a very easy process. It has got various challenges. And to enumerate those challenges, there are anatomical challenges, there are microbiological challenges, and there are structural challenges. I would be talking about them. First of all, anatomical complexities. As I already showed, this landmark study clearly showed that less than 35% of the root canal surface it left untouched by conventional instrumentation. So it requires a lot of efforts to reach into each and every area, and the area where our instrumentation is not touching the walls, the irrigation flow becomes very, very difficult. So these anatomical intricacies, as this landmark study by Sequeira, it showed that especially in oval shape and wide canals, it becomes very difficult to clean all these areas because of intricate configuration. The second challenge, which is again a very, very big challenge, is the structure of the biofilm that we get in our root canal system. It is not just the bacteria are floating inside the root canal, that is the planktonic form. If it had been the case of just the planktonic form, that is the bacteria, they are floating inside the root canal, the case would have been very easy or not so difficult, I would say. But since our endodontic biofilm, it is a complex structure made up of lots of more than 30 to 40 bacterial species. They take part in endodontic biofilm, and the species are very, very resistant to antimicrobial treatments because of their inherent properties, the genetic structure, as well as the polymorphic substrate that they lay down, the EPS, the extracellular polymorphic substrate, which forms the biometrics, the matrix for the biofilm. It makes the bacterial cells to get adhered to the root canal walls and also to reach inside the dentinal tubules. So, in such cases, it becomes very, very difficult to remove bacterial biofilm just by simple irrigation technique or just by simple syringe irrigation. So the complexities of root canal spaces are various. It is not just a simple fluid movement. There is no fluid movement or little fluid movement inside the root canal system. There is very low oxygen supply. The pH is very low. The diffusion of medicament becomes very, very difficult because of EPS, the matrix of the biofilm. Also, our dentine structure has a very special property of buffering the antimicrobial agents. So the antimicrobial agents, once they reach to the root canal dentinal walls, the buffering capacity of dentin, it hampers their penetration inside the dentinal tubules. And that's the reason why, if we think that we have placed a calcium hydroxide dressing or hypochlorite, suppose we have given a syringe 5 ml irrigation of sodium hypochlorite, can we do the entire root canal treatment with that? It is not possible. Why? Because we have to exchange it repetitively, because we have dentin buffering capacity inside the root canal system. Also, deeper penetration of bacteria into the dentinal tubules, it is the various studies have already shown that almost 200 to 300 micrometer bacteria, they penetrate deep inside the dentinal tubules, which becomes very, very difficult for any irrigating solution to reach into those dentinal tubules. Especially, we have to understand that especially after our rotary instrumentation, they work inside the root canal system, they create a debris or the smear layer. So the smear layer, already it is formed of lots of inorganic debris, organic tissue like pulp tissue, necrotic tissue, as well as dead bacteria, their endotoxins. So this plug formation onto the dentinal tubules opening, it makes even more difficult for our irrigating solution to deeply penetrate into the dentinal tubules. Also, the special properties of our bacteria, that is altered gene expressions, and the extracellular polymorphic substance, they all have great resistance to any antimicrobial substance or the antimicrobial solution. That is the reason it becomes very complex for it makes our root canal space very complex. As I told you about dentine structure, it is a complex structure made up of multiple intertubular and peritubular dentine. And once we remove the contents of the root canal system, because of the smear layer, these dentinal tubules openings get clogged by the smear layer, which makes it even more difficult for our irrigating solution to penetrate inside the dentinal tubules. This is the structure of biofilm shown by the amazing and most beautiful studies of biofilm I have seen is by Dr. Domenico Ricci, and he shows clearly shows very much evidence-based clinical cases in which he shows the presence of biofilm inside the root canal system, also onto the extra root surface when there is a periapical lesion. So if you see these biofilm structure, it is made up of various bacterial cells, cocci as well as bacilli. And if you see the lower image, in which it is clearly seen that the penetration of bacterial cells or the cocci inside the dentinal tubules deeper. So these pictures, if we look at them clearly, then we can only understand the complexity of root canal system and the importance of irrigating solutions and irrigation technique. So there are more than 30 species take part in endodontic biofilm, and they are actually very resistant. Another very interesting study by Dr. Anil Kishan says that it is not just the bacteria or the bacterial species which are present into the biofilm, which creates inflammatory potential, which has inflammatory potential and pathogenic potential, but even in the absence of any bacterial species, the extracellular substance or the EPS, the extracellular polymeric substance of the biofilm, it in itself is a very inflammatory potential and creates a low grade inflammation. So it is not just the bacteria, but the EPS as well as extracellular DNA of the bacterial strain, which has the similar potential of creating inflammatory response in the periradicular area or the periradicular tissue. So it is not just the bacteria that we have to take care of, but the entire biofilm that we need to remove. The third big challenge which comes is the structural challenge, because we are living in the era of minimally invasive endodontics, as we have already seen the consequences of removing lots and lots of dentinal or the original healthy tooth structure in form of tooth fracture, cusp fracture, or vertical root fracture. So now we are very careful and cautious to remove as minimum as possible dentinal structure from in our root canal treatment. So since we are living in a minimally invasive endodontic era, it is our duty to understand how can we overcome these structural challenges. This is one of the very interesting study by Dr. Prasanna Nilkanthan, who has actually compared two major factors in irrigation. One is size of the instrument as well as the technique of agitation, because there were various studies, but the combination of these two clinically relevant parameters were lacking. So what he did, he used mandibular premolars, the oval shaped canal, and he saw the effect of different sizes, that is 20 number size and 40 number size files, as well as syringe irrigation and passive ultrasonic irrigation. And what he saw is that in oval shaped canal, thus as the size increases, if we don't consider any irrigation activation technique and we talk only about size, then as the size increases, like 40 size would be better, having better or clearer canal as compared to 20 size in a oval shaped canal, which is obvious because we would be removing more of the bacterial biofilm or the disruption of biofilm with the larger size. But if we are using agitation techniques like passive ultrasonic irrigation technique, then in such cases both the sizes, be it a small size of 20 or a large size of 40, there is no difference in the cleaning efficacy of any of these sizes. So when the irrigants were ultrasonically activated, a smaller preparation resulted in canal that were as clean as larger preparation, which is a very good news according to I feel so. So the minimally invasive endodontics, it relies on smaller preparation because we try to rely more on our irrigation is a solution as well as irrigation technique. So what better than passive ultrasonic irrigation? But if you talk about just the syringe irrigation, so when we see only syringe irrigation, just the mechanical shear forces, then the size which is higher would be having clean canal as compared to small canal. So the conclusion is very clear. If you really want to preserve the root canal dentine or the root canal structure, it is important to incorporate agitation or activation technique in your practice. You cannot just do minimal preparation and do just simple syringe irrigation, then you won't be getting result because that would be a completely unclean canal. So I think this is a very clinically relevant study. This another study by the Prasanna Nilkanthan sir again is very important when we talk about minimally invasive preparation, like in truss access. So what happens in truss access is we create orifices directed access cavity. We don't remove the entire pulp chamber roof. So we try to take a small orifice, make small orifices and directly directing towards the orifice of our root canal. So in this we the idea is to save more of dentine structure. But what is happening here is we are not able to remove the pulpal tissue or the remnants of pulp tissue from the pulp chamber, which is very obvious. We cannot remove the pulp chamber which is present in the pulp chamber area. So it becomes very difficult to remove this, and we need specialized instruments and techniques to remove. So you cannot perform this technique without any expertise, skills, as well as instruments. Otherwise, you will end up into leaving the biofilm present into the pulp chamber area intact. So another interesting aspect of this study was that even though the pulp chamber was not clean, But if you look at the isthmus area as well as in the root canals at various levels, like in coronal third, middle third, and apical third, then there was no much difference between a conventional access cavity, that is the control group, and a truss cavity. So this is very interesting, because what we think is it is always that a cavity is not able to clean our root canal system or the isthmus area, but at the same time our traditional cavity also is not able to do the same if we are not activating the solution. So, another very interesting article by Dr. Prasanna Nilkanta and Nilkishan sir is the effect of root canal irrigants on dentine. So, everybody is talking about, or we will be talking about, use of lots and lots of irrigating solution. But how are they affecting our dentine? It's very crucial, and it's not a new concept that the micro hardness, the modulus of elasticity and flexural strength of dentine is getting deteriorated with the use of sodium hypochlorite, because of the obvious collagenase activity of sodium hypochlorite. The pulpal dissolution, which is the key factor because of which we are using, has a collagen dissolving property. So the same property is deleterious for our dentine, and it creates deproteinization channels inside the dentine. And the use of EDTA as a chelating agent, again, it opens the dentinal tubules. So the combination itself, it creates it makes our dentinal structure, which has compromised flexural strength, micro hardness, as well as the modulus of elasticity. So one has to be it is a difficult situation, because we have to use irrigating solution, that too in good amount, but at the same time we have to understand the consequences of using this irrigating solution onto our root canal dentine. So it's like a double sided sword in our endodontics. So what happens to different irrigating solutions on the bond strength of our sealer is that continuous chelation technique that I would be speaking later is it is better for sealers like epoxy resin based sealer. And for sealers like bioceramic sealer, it has got the problem with epoxy resin. If you are using a sodium hypochlorite as the last irrigating solution, then it compromises the bond strength of your AH plus or other epoxy resin based sealer. While in cases of bioceramic sealer, the final irrigating solution suggested is either distilled water or the normal saline, because all other irrigating solution are compromising the bond strength of bioceramic sealer with the dentine. So it is in various studies, the alternative use of EDTA sodium hypochlorite has been seen, and it shows that the micro hardness of dentine is definitely compromised by this combination. Now, when we talk about irrigating solutions, we need to understand the objectives of irrigation. We have three major objectives. One is mechanical objective, that is to rinse out or to remove the debris which is present, or it is just like the flow of water, and the flow of water would create shear stresses onto the root canal walls and would dislodge or disengage the debris or the biofilm, which can be disengaged just by the mechanical action. At the same time, it gives a lubricating action also. The chemical objectives are to dissolve the organic as well as inorganic tissue, and to prevent the formation of a smear layer, and if it has already formed, then to dissolve the smear layer, which is very important. Biological objectives are related to the safety of their use, and it should not be very toxic to our periradicular tissue. So the process is the objectives are very clear. So when we talk about isotonic saline or distilled water, so if you can understand the first objective, that is a mechanical, it is as we clearly say that it is a useless irrigating solution, but nothing is useless, because if you ask, then this these isotonic saline and distilled water, they do have their role in the mechanical dislodgement or mechanical action of dislodgement of various debris and the per canal contents by means of mechanical dislodgement. So here there is no chemical action or biological objective which has been proved, but the mechanical objective is useful, especially when we use this solution in cases when we have acute apical periapical abscess. Then a patient comes with exudates, and the moment we open the chamber, then exudates comes out, and in those moments we cannot use sodium hypochlorite because sodium hypochlorite tends to thicken our pus exudate. So in such cases, these isotonic saline solutions or distilled water, they are helpful by means of their mechanical action of removal of the exudate from the root canal. Also during the by for separating two different irrigating solutions, like in between sodium hypochlorite, EDTA or chlorhexidine, we have to separate them. Then in those cases, this irrigating solution is very useful. So we should be understanding the use of this irrigating solution also. But then the old and gold, I would say, is the sodium hypochlorite, because it is the most widely used irrigating solution because of its mainly two properties, that is antimicrobial and tissue dissolution. And if you see that it is not the antimicrobial property because of which we are bound to use this solution, but it is a tissue dissolution property which is unique to the solution, which makes it really unique. Even though the taste, the toxicity, all those things we have to compromise, but because of its tissue dissolution property, which is not there in any other irrigating solution, we have to use this. So the mode of action of sodium hypochlorite is different at different pH. At pH 9 or above, that is at alkaline, it creates OCl minus, that is hypochlorite ions. At neutral pH, it creates hypochlorous acid. Then below pH 4, it becomes a chlorine gas. So if you see that hypochlorous ions are responsible for their antibacterial property, that is around neutral pH, but for tissue dissolution property, we need hypochlorite ion. That is why we need higher pH solution for its tissue dissolution property. If you talk about the concentration for these actions, then for antibacterial action, even the 0.5% solution of sodium hypochlorite is as good as 5.25% solution. So if you think that we are using higher concentration for antibacterial property, that is wrong. We need to use higher concentration or acceptable limit of higher concentration of sodium hypochlorite because of its tissue dissolution effect. Because if you see here, the concentration as it increases the tissue dissolving property of hypochlorite. Also, the more we replenish the solution, better is the property or better is the effect. The temperature increase definitely increase the tissue dissolution property. Amount of organic matter, as I discussed, the amount of time that we need to use any irrigating solution, especially hypochlorite, it depends upon the condition of the tooth. You cannot generalize the amount of time for all the cases. Like in a freshly exposed or a vital tooth, the amount of time can be less, but in cases like long standing chronic cases or retreatment cases where you are expecting a lot of biofilm already present into the root canal system and lots of organic tissue, in such cases you need to dedicate more time for irrigation. Then frequency and intensity of agitation, it enhances the tissue dissolution property, and canal preparation size, obviously it enhances the tissue dissolution property. So the volume of solution probably is definitely the more important factor. That is why we keep talking about multiple replenishment of sodium hypochlorite as compared to the concentration. So if you want to, you don't want to use very high concentration like 5.25% because of its toxicity and risk of periradicular extrusion. Then if you are using 3% hypochlorite, 1% hypochlorite, or 2.5% hypochlorite, then you need to understand that in that case we have to replenish the solution again and again and more. So obviously, sodium hypochlorite is criticized for its unpleasant taste and toxicity, and it cannot remove inorganic smear layer. So as I told you, for how long we have to use irrigating solution is the trickiest question. Standing or sitting in 2021, we don't have a one-word answer for this question. We cannot just generalize this answer that yes, we need to give 30 minutes, 40 minutes, 15 minutes to this much of percentage. Thousands and thousands of meaningful studies, but none of them can prove the role of concentration and time factor in sodium hypochlorite. So what I believe is it is the case which determines the time. It is the case which the clinical presentation of a case which actually governs the time required for irrigating solution to be used. So if you see all these cases, then each case required different amount of time and different concentration. More than concentration, the amount of solution that we need to use is also different for different cases. For single canal, vital tooth, non-vital tooth, retreatment, exudate case. So in depending upon the number of canals, that condition of the pulp status, that is the case a normal non-surgical treatment or a retreatment case, it's a periapical abscess case. All these factors, they determine the amount of solution to be used and the time in for which we have to use irrigating solution. So clearly the study says that the multiple instruments and higher the volume of irrigation and long retention time of sodium hypochlorite irrigant had positive influences on intracanal disinfection, no doubt about it. And effect of biofilm, obviously whenever you expect biofilm adhered into the root canal system, then higher concentration are more desirable, or multiple replenishment as well as the agitation is very very important to remove such adherent biofilm. You cannot expect just a syringe irrigation to remove this biofilm structure from the root canal system. What happens if hypochlorite gets extruded? Then the presentation can be like this: a profuse bleeding, sudden profuse bleeding from the root canals. You can see extreme pain or swelling in the region. Then the swelling, the color of the swelling will keep on changing for another 7 to 10 days. The management would be the patient's explanation of the case or the problem and cold compression for initial 24 hours. Then after that, you can give a close dressing on the same day if you can get if you can stop the bleeding, or you can get the dry canal, or if you are not getting the dry canal on the same day, you can recall patient after 24 to 48 hours and give a close dressing with calcium hydroxide. You need to put the patient on analgesic, antibiotics, and sometimes steroid. I feel assurance is, or reassurance to the patient is, the most important key factor in such cases. When we talk about the other irrigating solution, which is chlorhexidine, it is bisbiguanide used in two concentration, 0.2 and 2%. It is a very good irrigating solution and a very potent antimicrobial agent. But the problem here is it is not a tissue dissolving, it doesn't have tissue dissolving property. And the interaction between sodium hypochlorite and chlorhexidine and formation of this parachloranilene, which is an orange precipitate, which is said to be a toxic agent or carcinogenic agent, is a bigger issue. Though substantivity property or long-term substantial release is there with chlorhexidine, so there are some people and certain studies which promote the use of chlorhexidine in cases of retreatment as the last irrigating solution. So, there are various studies which say that it can be used as a final rinse, while other studies they have proved that it is of no use. So, it is individual use. In a recent systemic review, Ange et al. Demonstrated that abstaining from using 2% chlorhexidine as an adjunct irrigant to NaCl was associated with superior periapical healing. So, yes, there are studies which do not recommend the use of chlorhexidine in long-term trials. So if you have to use sodium chlorhexidine for its substantial property. The clinical recommendation would be in cases when you have perforations, large perforations, or open apices. In such cases, it is useful because of the toxicity of sodium hypochlorite. So, when maximum antimicrobial effect is desirable as a final rinse after EDTA, so we can use chlorhexidine as a final rinse, and it improves the bonding of the sealer with the dentine. Now coming to the decalcifying agent, which plays very important role. There are two types. One is strong chelating agents or weak chelating agents. So the most important irrigating solution in this category that we use is EDTA. So we use it in either solution form or viscous form or gel form, but solution form is more common. The use is clear. It removes the inorganic layer which keeps on forming with every rotary instrument. You are creating a smear layer which is made up of lots of dentinal chips and inorganic tissue. So with the sodium hypochlorite, you can just remove the organic part of this smear layer, that is a pulp tissue, bacterial dead cells, endotoxins, but you cannot remove the inorganic part with sodium hypochlorite. That is why there is an absolute need of use of this EDTA solution after sodium hypochlorite. So when there are various studies which have already proved that there is no doubt for smear layer removal, we need EDTA solution after sodium hypochlorite. What happens if we mix EDTA with sodium hypochlorite? Why can't we do that? Otherwise, it would be very easy. But we cannot do that. Why? Because EDTA, it does not lose its property if we mix. But what happens? It takes up all the free chlorine which is present into the sodium hypochlorite solution. So it takes up all tissue dissolution property of sodium hypochlorite, and there is no free chlorine which is available. So we have to be very careful when you are using sodium hypochlorite and EDTA as alternate solutions. Then you need to rinse every time you use EDTA, you have to rinse it thoroughly with distilled water or with normal saline, so that no remnants of EDTA are there and they do not affect sodium hypochlorite and its action. What would happen if you mix chlorhexidine and EDTA? It would form a white color, salt or precipitate. Important role of temperature. The role of temperature is only good for sodium hypochlorite because it enhances its tissue dissolution property. While if you heat EDTA or chlorhexidine, it definitely degrades their property. The another interesting concept in irrigation is it is not so new. It is from 1990s. We are using it's a newer material which is etidronic acid or HEDP, 1-hydroxyethane 1-diphosphonic acid. Etidronate. It is not a new drug or material. It is already used for cases like osteoporosis or osteoarthritis cases patients. So it has anti-inflammatory properties also. It is why it is helpful here is the lower concentration like 2.5% of sodium hypochlorite can be mixed with etidronate as etidronate salt, and they can be used as continuous chelation process. So the benefit is if you are mixing a chelating agent with sodium hypochlorite and it is not degrading the property of sodium hypochlorite, then it is so good, because if you are using it thoroughly during instrumentation, there won't be any debris formation or smear layer formation. So we are free of comparatively free of smear layer formation, and it is so useful because we don't have to remove a smear layer towards the end, and penetration of irrigating solution into the dentinal tubules and other intricacies would be better. So there are many other irrigating solution into the market, and I cannot just take them in detail, but yes, there are many more irrigating solution into the market. Now there comes after solution, there comes the mode of application of this irrigating solution. The first and primary mode of irrigation application is by syringe. So the two effects that a syringe irrigation takes care do take is one, chemical effect and the mechanical effect. As I already said, the mechanical effect is just like a tap of water. When you open it, takes down all the loose debris along with the flow of the liquid. But for its chemical effect is mainly because of the irrigating solution. So these effects are basically dependent upon the flow, the frequency of replenishment, application of force, and restriction of the flow because of the closed circuit of root canal system. So when we talk about pressure that is created, or pressure, the importance of pressure is very important. Why? Because of the pressure, there would be mechanical effect of irrigating solution. So we have to understand that we cannot use just 2 ml 3 ml syringes. The best is to use higher the bigger syringes like 10 ml syringes. But the ideal most syringe that we are using day to day in our practice is a 5 ml syringe at least. We cannot use 3 ml syringe for irrigating solution, otherwise pressure would be less. So 5 ml syringe is indicated, and a lure lock design is definitely required, because we don't want, because of high pressure, the irrigating solution gets spilled all over the patient, or it can create lots of complications if it goes into the eyes, or it can stain the bleaching effect on the clothes. So it has to be a lure lock design. Then comes with the syringe, we have to use different needles. What size of needle we should be using? It all depends upon what is the size of your preparation. But anyways, you should make sure that your irrigating needle should be reaching to the apical 1/3 area of the root canal, which is a major mistake that we all do in our day-to-day practice. We keep on using different irrigating needles, be it a side vented needle, but we don't understand at what length they are reaching. So it is really, really important to take care of the working length, mark a rubber stopper, and understand that your side vented needle, the gauge selection should be such that it reaches into the last 2 millimeter of your working length. If it is not reaching there, it means it is of no use. Your irrigating solution will not reach there. So obviously, because there are many designs of irrigating needles, and we should use safe ended needles, that is, they are closed at their distal end, but they have proximal openings. So they are always safer. Now we have polyamide, more than metal, we are using polyamide kind of these syringes, needles, because they are very flexible, they are very thin, and they can be reached into the apical most area, even in a very minimal preparation of 4%, or in cases of minimally invasive preparations. So there are two types of flow of solutions. Can be laminar, that is if you are using 0.01 ml per second. But if your solution is going more at higher flow rates like 0.26 ml per second, it is not turbulent, but yes, it is unsteady flow. So the flow is very important, because for higher shear stresses you need to put more flow rate, so that the shear stresses are created and mechanical disruption of biofilm can take place. There are various flow patterns of different needles that can be seen here in these pictures. Our tip placement should be such that it reaches at least 1 mm to 2 mm from our working length. So our preparation size of around 25, 30, or 35, we have to select our irrigation tip according to our preparation size and taper. And only when our irrigation tip is reaching into the last 1 to 2 mm, we can be sure that our irrigating solution is reaching there. What shear stresses are the stresses which are created by irrigating solution touching the side walls of our root canal dentine, and they disrupt and helps in detachment of biofilm and other structure from the root canal wall. So obviously we use close-ended needles, and if you see these pictures, the side shear walls can be seen. Also, we can see that our irrigating solutions are reaching only 1 millimeter beyond these openings. So we have to be very clear in our mind that if you are putting, just passively putting your irrigating needles and not understanding where it is reaching, you might be just irrigating the middle third of your root canal. So if you really want a complete or appropriate irrigating disinfection, then your irrigating needle should reach to last 2 millimeter of your working length. That means you have to select your the gauge of your irrigating needle. At the same time, it should be completely passive, it should not get stuck. As we all know, there is a vapor lock effect inside the root canal dentine. We have to understand and make use make to try to open these vapor lock effect, and that can be done by, you can see this case where we are just irrigating. This is the irrigating needle, and I have put my rubber stopper 2 millimeters short of the working length, and under microscope also I should be seeing this rubber stop touching my reference point. And then this is the ultra smart by COXO, which is an portable ultrasonic agitation device. This also comes with the tips, detachable tips, and we have to put stopper here again. If you are not putting stoppers on the irrigation tips and on these devices, then you might not be reaching to the desirable working length. So this is how you can get a clean canal. Now coming to the agitation technique. Why do we need agitation is a very important question. We need agitation because the biofilm structure inside the root canal wall is adherent structure, as I told. It is not easily removed just by passive irrigation by syringe. So to have that scrubbing motion or to remove the adherent biofilm from the root canal wall, we have to agitate our liquid. There is a difference between agitation and activation. Agitation is a mechanical process of moving a liquid inside the root canal system to give it energy so that it moves in a way that it produces different movement inside the liquid and helps in detachment of the biofilm from the root canal wall. So it can be done in two ways. One is the main bulk flow, that is the diffusion, and other is convection. So diffusion, you can see like in this red area, the main root canal, if you put liquid or irrigating solution, it is mainly the bulk flow. And then if you want to take those irrigating solution into these tiny tubules, you have to use convection or the diffusion property, which can be done with the help of ultrasonic activation. Only with the ultrasonic activation your irrigating solution can reach into the dentinal tubules. And as I already said, our bacteria may penetrate around 200 to 300 micrometer inside the dentinal tubules. The size of dentinal tubule is so small, it is almost 2.5 micrometer. So for our irrigating solution to penetrate these small areas, you have to activate them with ultrasonic activation. So this is an interesting study, and there are many more like this, which already said that mechanical activation of irrigation devices is very beneficial for root canal treatment, and it's not, syringe irrigation is not sufficient for irrigation to penetrate into the deeper areas of root canal system, like in apical 1/3 area. Also inside the dentinal tubules, it is impossible. So there are various way of doing this activation. One is the basic most is the manual activation, which can be done with the last gutta percha that we select for our obturation, the master apical gutta percha. We can just use a locking tweezer, and we can just make the marking till what length we have to take it, and with the repeated motion of 100 strokes of 2 millimeter of amplitude in up and down direction, we can just help in removal of this vapor lock effect. And this is the easiest way of doing but it is a time taking and mechanical process. Then we have some really interesting devices in terms of sonic activation, which uses a frequency of 20 to 20,000 hertz. There are various companies and devices which use tips like polyamide tips or polycarbonate tips, and they are helpful in cases when you have curved canals. So they in cases like this, when you have extreme curvatures and periapical pathology, then you cannot take the risk of using metallic tips inside these curvatures or apical 3 to 4 because of the chances of fracture. In such cases, it is important to use these polyamide tips. But the gold standard in activation still remains the ultrasonic activation. And the activation is basically because of the two main effect of ultrasonic, that is cavitation and acoustic streaming. As we all know, in this we can understand this is the ultra smart by COXO, and this is how it creates acoustic streaming and cavitation effect inside the root canal. You can clearly see the bubble formation with this device. This device is a very lightweight device, and it comes once you switch it on, the light also focus inside the root canal. So it is an easy device to use as a handheld device for ultrasonic activation. So cases like this, when you have a retreatment cases and you need to remove the entire the caries and the gatapacha, but you see in such cases sometimes removal of gatapacha from each and every wall of root canal is not so easy. So you feel, or even on radiograph you don't see, but under microscope you see that gatapacha gets stuck. So in such cases, when you use this ultrasonic agitation device like ultrasmart, it becomes it has very thin tip, so it becomes a very minimally invasive process, and at the same time it removes all the obstruction, as well as it gives a good agitation and activation of root canal irrigant. There are sufficient studies which promotes the use of using ultrasonic under magnification, and it helps removal of gatapacha. So this is how it can be done. A recent case where it was again a completely failed tooth with periapical pathology, the working length and everything was fine. But in such cases also, there is no extra canal. What is lacking here is the complete cleaning of the system. So here also, the wide distal canal, I think, is the reason where there was incomplete cleaning and sealing. So this is how it can be done. The other thing which can be done is continuous ultrasonic irrigation, which comes as few. It is not so common. There are few couple of companies which produce this continuous ultrasonic irrigation. So ultrasonic activation irrigation is definitely it reduces significant amount of bacterial reduction inside the root canal system, and definitely improves the outcome of endodontic treatment. When we compare passive ultrasonic irrigation like ultrasmart and we compare syringe irrigation and we compare sonic activation, so there are studies which says that ultrasonic irrigation is definitely is better than any other irrigation technique that is used here. In cases like this is an interesting study. They say that if you are checking your activation on a dentinal disc, uh, on a surface of dentine, then you won't be seeing any difference with any device. Even your syringe irrigation would be as good as your any activation device. But if you really want to see the effect onto the dentinal tubules or into the intricacies, then you would be seeing that only ultrasonic activation can take your irrigating solution into those intricacies or into those dentinal tubules. In cases of isthmus, if you are using a high flow of syringe irrigation, you can clean that. You don't actually need ultrasonic activation, but you need to use high flow of syringe irrigation. But obviously with ultrasonic irrigation it is always safe, and you can remove the contents of present inside the isthmus or inside these intricate areas of root canal. The other technique is negative pressure agitation, like endovac system. We all know that there is microcannula and macrocannula attached, and there is a continuous irrigation and sucking process because of there is a constant negative pressure, because of which a continuous flow of irrigating solution keeps on happening, and it keeps on taking the irrigating solution from microcannula and helps in good irrigation. There are various studies which says that this is good. It is definitely good, but it requires a special device. It requires a special assembly, and is not so portable, or is not so easy. So I feel still ultrasonic irrigation still is becomes a very choice in every clinic, in every setup. You have portable thing units also, and you have your ultrasonic machines also, where you can just attach your ultrasonic files. Other techniques are PIPs, photon induced photoacoustic streaming, and lasers, and they are really, really promising. They give promising results in cases of retreatment, other cases. But they obviously, RBM YAG lasers, they are very expensive devices, and very few practices are using them in their day to day practice. They are not so common. This is again a good device or good instrument which we can use routinely at 1000 above rpm. If you are using XP endo finisher, it also gives a lot of agitation of your irrigating solution, and there are many studies which says that it helps in removal of biofilm. The other things are canal brushes, which comes with coltine and maybe dentsply. So they also helps in mechanical agitation of irrigation solution. Now, coming to the protocol that I would like to suggest is a continuous thorough irrigation with the help of 2.5 to 5% sodium hypochlorite throughout the instrumentation until we get the final taper, final shape, final size. We need to use irrigating solution from our access opening till our last instrument. With every instrument, after every instrument, we need to replenish irrigating solution after every instrument. Then comes the activation. We can heat sodium hypochlorite. We can use system B pluggers or the pluggers from our thermoplastic unit. We can heat sodium hypochlorite intracanal, which always has better effect. And 30 seconds of agitation or activation with the help of ultrasonic for each canal. And we should be doing 5 cycles per canal. So 30 seconds per canal and 5 cycles per canal is the final activation of our irrigating liquid. After we are done with sodium hypochlorite, we would be rinsing it with distilled water or normal saline, and then we will be using any chelating agents like citric acid or EDTA. The time required here is 1 to 2 minutes. As I told, we should not be heating these liquids because they deteriorates their property. So the smear layer removal becomes even more difficult. Then final rinsing would be more recommended if you do it with distilled water, because you are always safe if you are using epoxy resin as sealer or you are using bioceramic as sealer. But certain studies still says that EDTA as last liquid is also good for bond strength of epoxy resin based sealer to dentine. So it's up to your choice. Some people try to use chlorhexidine because of its substantivity property as last liquid. But I feel using a distilled water as last liquid is always safer. And then you just dry the canals or use your paper points. If you find the canals are completely dry, you are ready to go for obturation. So very from the entire presentation, few take home messages I would like to share here again would be: irrigation in endodontics plays a major role in disinfection, and adequate time should be given to the irrigation. Hypochlorite remains the oldest gold solution so far, no doubt about it. Role of EDTA or continuous chelation technique sounds promising. I won't say in future, but in present. Syringe irrigation using syringe irrigation using 5 ml syringes and fine needles presents several advantages. Close-ended needles need to be placed 1 millimeter short of working length. Open-ended needles can be placed 2 to 3 millimeters short of working length. During irrigation, the needles should be moved continuously longitudinally inside the root canal, up and down, with maximum insertion. Root canal needs to be enlarged to at least size 30 or 35, combined with increased taper to allow irrigant penetration to working length. A relatively high flow rate seems to be better for mechanical as well as chemical effect. Selection of irrigation tip and size is really crucial and case dependent. No two irrigating solutions should be mixed. Distilled water as last irrigation solution is a choice if you are using bioceramic sealers or epoxy resin sealers. Sufficient time should be given to irrigation as case to case. Mechanical agitation is very, very important, and we cannot just rely on syringe irrigation. Ultrasonic, sonic, manual dynamic activation, lasers, all these devices are really important for activation of of a variegating solution. But in day-to-day practice, we can use, or we should use, we can use ultrasonic activation, which becomes very easy and practical in our day-to-day practice. With this, I would like to conclude my presentation showing this case of mine, which was a case which I only did around 4 years back when it came to me. So this patient comes with a mobility, grade 2 mobility in this tooth. The case appeared to be like a vertical root fracture because of J-shaped radiolucency. Where I could not see any fracture in CVCT. Patient was not ready for the extraction, so we thought of giving it a try and tried to think what went wrong here. So when I just removed the obturating material from the system, and I saw there was no extra canal. It was a clear cut C-shaped canal case, and I just gave calcium hydrox after complete thorough irrigation, lots and lots of irrigation with sodium hypochlorite and EDTA and continuous escalation technique. I just give intracanal medicaments with calcium hydroxide once the canals were dry. Around it took me 3 to 4 sittings for getting completely dry canals. So almost after 1.5 months, I obturated the case. So once I did my obturation, we can see the follow-up of 1 month, 2 months. So these are the follow-ups, and now I have already seen the follow-up of 4 years, and it is showing promising result with no mobility and complete recovery of the tooth. So such cases, they show the importance of irrigation in endodontics, and importance why we should not just think that it's a case of extraction. We should give it a try. With this, I would like to thank you all for your patient hearing, and I would like to take some questions that you have in your mind, and I would like to answer them as much as I can. Thank you. You can follow
Many
me. You can follow me and many other cases on this endodontic expertise page on Facebook and Insta, and you would be seeing some meaningful work done by many good practitioners, and they will help you in your practice. Thank you. Yes, Carol.
many friends, Dr. Shana, excellent lecture.
Thank you.
Now I will pick up some question who is left on the comment. Some of the dentists say I pick up. So he said it's excellent, and this is the very interesting, amazing. Okay, let's see the comment of question. This one.
There's one question is, what is the difference between irrigation and activation? I can see that in the chat box.
Which one? Sorry.
Uh,
Which one you?
there is a question, what is the difference between irrigation and activation?
Okay, I saw it. This one.
Yeah, yeah. So irrigation is basically an using irrigating solution for the cleaning of our root canal system. So we are using different irrigating solution for the purpose of, or for the objective of cleaning of our root canal system. That is irrigation. But activation is a process of giving mechanical energy or the energy in form of either sonic activation, ultrasonic activation, manual energy in terms for its movement of liquid inside the root canal system. As I said, there are two movement, like one main bulk flow movement, diffusion and convection, because of which the irrigating solution will flow into the intricacies of root canal system. Also because there is a vapor lock effect, so we want our irrigating solution to reach to the apical third area, which is very important. Otherwise, you see, because of the closed system, our irrigating solution will not reach into the apical one third area, which is required. Can you illustrate the effect of irrigants on bond strength of sealer? I have shown a couple of studies here. Definitely, bond strength of sealer gets affected by the irrigant, especially the last irrigant that we use. So the if you are using an epoxy resin based sealer like AH plus, your last solution should never be sodium hypochlorite. You can use, some study says that EDTA as last solution, it opens the collagen and it is helpful for bonding of epoxy resin based sealer. But again, there are certain studies which says that the last irrigating solution should be distilled water or normal saline. So it is important to understand that sodium hypochlorite should not be the last irrigating solution if you are planning to obturate the case with epoxy resin based sealer, or with bioceramic sealer also your last solution should be distilled water. Ultrasonic tips have tended. Sorry, Carol, I think I can take the question myself. Is it okay?
Okay, but it's better I can pick up in the screen and you can
Okay,
answer it. Okay,
okay,
I
so
pick
you
up now. You are saying that one is. Uh, Sorry, I pick up the next one. Can you instruction? Does this one already answer or not?
yes, it is answered. This is answered.
And and this one?
No. Which one is the best root canal sealant? I feel he's asking sealer nowadays. I feel there is nothing best for all cases. Neither it is irrigant, nor it is sealer, nor it is instrument. uh, there is no cookbook recipe for each and every case. We as the clinician, we as the expert, it is we who decide our best instrument or material for any particular case. So best, if I say bioceramics are the best, it is not true. If I say epoxy resin are best, it might not be true. People are happy and giving wonderful result even with a zinc oxide eugenol based sealer. So it is more of your expertise and your case selection which determines which sealer you have to use. So best for all cases is not the right term. I think so.
Okay, this is the last question. Other question you can answer below the comment because
I would
okay.
do. I would do that. I would
Okay.
do that, Carol. Ultrasonic should be used till full working length or short of it. As I said, our irrigation tip should be 2 millimeter or 1 millimeter at least short of our working length. Also, ultrasonic should be at least 2 to 3 millimeters short of our working length. Otherwise, you would end up into extrusion of irrigating solution in periradicular area. So ultrasonic, since because of its acoustic streaming and cavitation effect, it has a tendency of pushing or spreading the movement of irrigating solution. So it is important to use it short of working length, at least 2 to 3 millimeter.
Okay, thanks for Dr. Shalu. That's all for today. Thanks for your excellent lectures.
Thank
Okay,
you.
thank you. So um, now I will pick up the lucky person who left the comment in our page. And today our gift is one Titan handpiece. From here, I want to remind the dentist who is from Indian they have the special offer during the Diwali festival. If you want to buy any product of COXO, please connect with our local dealer. Now we got the comment. Mm-hmm. Who is the lucky person? Let's start. Okay, here is the winner. The winner, we will connect you. We will connect you after this lecture. Last, I will leave the certificate link on the comment. If any dentist want the certificate, please apply it within 5 hours later. Okay, that's all for today. Thanks for your attention. Thanks for follow COXO page. And next week we have a new webinar. Please keep focal to COXO page. Bye bye everyone. Bye.